So today we will talk about prostaglandins and non-steroidal anti-inflammatory drugs. As a practice, we should always study non-steroidal anti-inflammatory drugs along with prostaglandins, because non-steroidal anti-inflammatory drugs, they act by inhibiting synthesis of prostaglandins. So rather than studying them as a pharmacological actions of NSAIDs, we should rather study prostaglandins, and the opposite effect will be of NSAIDs, because there is no other mechanism of NSAIDs other than inhibition of synthesis of prostaglandins. Prostaglandins, the name suggests like it's similar to prostate, prosta. So basically in 1930s it was observed that semen or sperms, they produce very strong contraction in the uterus and they cause hypotension, severe hypotension in animals. It was found out that there is some substance that is present in the semen, and it was believed that this is secreted by prostate gland. That is why the name was given prostaglandins. This was, after almost 30-40 years, in 1970s we can say, that we came to know that NSAIDs, they act through inhibition of prostaglandins, and exact nature of prostaglandins was found out. And we should remember that Wayne, Samuelson, and Strom, Bergstrom, they received Nobel Prize in 1982 for this discovery, for discovering the mechanism of action of NSAIDs and these discoveries on prostaglandins. So this took almost 50 years before we came to know about this. Now we know a lot about prostaglandins, their structure and how they are distributed. Remember, prostaglandins are most commonly distributed autocoids. They are present in almost every cell, and the action is very local. We don't find them circulating in the blood. The action is very local, in the vicinity only. So they are synthesized locally and they act there only. Synthesis also is dependent on availability of arachidonic acid, that is the compound that is derived from the lipid bilayer, from phospholipids. So if arachidonic acid is available, the cells can synthesize prostaglandins. We call it arachidonic acid. Arachidonic acid, as I said, is derived from phospholipids, bilayers, lipid bilayers, and it contains 20 carbon atoms. So actually, roughly we can remember that the base of all these autocoids which are having 20 carbon atoms, that is a prostanoic acid. Prostanoic acid is not naturally present in the body, but this is the general compound from where all these compounds can be derived. See, what is the structure of prostanoic acid? This is 5 carbon, and it is always better to remember that this is the 10th carbon. Then we can easily draw this: 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And from this side also, this will be 11, this is 12, 13, 14, 15, 16, 17, 18, 19, 20. This is prostanoic acid. If we see arachidonic acid, that is derived from, actually that is an isomer we can say, but arachidonic acid is different. Arachidonic acid, it contains 4 double bonds, and that is very important. Actually the nomenclature we have to remember. 20 carbons means icosa, E-I-C-O-S-A, icosa. And depending on the number of double bonds, we call them tetra or penta or tri. So when we say these compounds, they are icosa tetraenoic acid. Icosa tetraenoic acid. Icosa because 20 carbons are there, and tetraenoic means there are 4 double bonds. So we should see the structure of arachidonic acid. Arachidonic acid, it goes something like this. So again I remember it like this is 10th, this will be 9th, this is 8, this is 7, this is 6, 5, 4, 3, 2, 1, and here it will be 11, 12, 13, 14, 15, 16, 17, 18, 19 and 20. Icosa, and there are 4 enoic. 4 enoic is 5, this, 8, 11 and 14. So this is icosa 5, 8, 11, 14 tetraenoic acid. Arachidonic acid we call it. So these compounds are icosa tetraenoic acid. And leukotrienes. Leukotrienes we call them because they also has leuco. Leuco means they were derived from leukocytes, number 1. And triene means there are 3 double bonds. So that is why we call them leukotrienes. They are also derived from arachidonic acid. So from arachidonic acid, what do we get? There are 2 pathways. One is when arachidonic acid, it is acted by cyclooxygenase enzyme, another is by lipoxygenase. Through cyclooxygenase we get prostaglandins and thromboxane, and through lipoxygenase we get leukotrienes. So this is the diagram that is given in the books. From membrane phospholipids by action of phospholipase A. This is phospholipase A. This causes release of arachidonic acid. And from arachidonic acid, one pathway is through cyclooxygenase, another is through lipoxygenase. Through cyclooxygenase pathway, initially there is synthesis of PGG2. This 2, it shows that there are 2 double bonds. In arachidonic acid, we talked about 4 double bonds, 5, 8, 11 and 14. When we have this 2, this means there are 2 double bonds, and that is 5 and 14. 2 double bonds are there. So they are cyclic endoperoxides. This G2 is converted into H2. And remember, this PGH2 is a universal precursor for all other prostaglandins. It's a universal precursor. And which are those? How do I remember it? There is no ABC. We can remember that they are from A to I. There is no ABC. We have to remember. So B, E, F. GHI. So they are all alphabetically. So G2, H2, they are precursors, and from there, with the help of isomerases. Isomerases means there are slight differences in the structure. So what is synthesized? PGE2, PGD2 and PGF2 alpha. Alpha, beta, this also is a part, like if we see this structure, in many places we will find it is shown as this. Means this is basically, they are from this circle, from this ring, they are in the planes at 90 degree. So one is alpha, another is beta. So depending on the position of double bond, in which position it is, we call it F2 alpha. So these are synthesized by isomerases. Then prostacyclin synthase, this causes synthesis of PGI2, that further gets converted into 6-keto PGF1 alpha, but we always remember PGI2. Another is thromboxane A2, that is synthesized by thromboxane synthase. This thromboxane A2 is also converted into B2. There is thromboxane A1 also. Remember, here we are not talking about that one series. Here we are only talking about two series. One series is synthesized from linolenic acid. There is gamma levolenic acid, that gets converted into series 1, where we get PGH1, PGE1. Maybe we'll talk about that, but they are not very prevalent in the body. That is why their actions are limited. But one of the actions, some of the actions of PGE1 we will see. Thromboxane A1, it has actions opposite to thromboxane A2, but they are not very significant. That is why we always talk of this 2 series, that is synthesized from arachidonic acid. As I told you, remember, one series is derived from gamma levolenic acid. Lipoxygenase. What is this 12-HPETE? This is hydroperoxy. If it is HP, it means it is hydroperoxy icosahexatetraenoic. We talked about icosahexatetra. So this is icosahexatetraenoic. If it is HP, this is hydroperoxy. If it is HP, this is if it is HE, this is hydroxy icosahexatetraenoic acid. So there is no peroxy. So 5-HETE also are synthesized. But what is more important for us is there is synthesis of 5-HPETE, 5-hydroperoxy icosahexatetraenoic acid, that gets converted into LTA4, that is leukotriene A4. As I said, they are leukotriene. Leukotriene means 3 double bonds consecutively. When we say 4, this means it has 4 double bonds. So one double bond also is situated in the side chain, but these 3 double bonds, suppose I show here one double bond, second and third. So they are situated consecutively. That is why we call it triene. So these 3 double bonds are there, so we will call them triene, but depending on, there may be other double bonds here, depending on that we will find that in subscript. So when we have this LTA4, means 3 double bonds are consecutively present, so it is leukotriene, and there are overall 4 double bonds, so that is leukotriene A4 we are talking about. This A4 also gets converted into B4 and C4. They have their actions, and C4 gets converted into D4 and E4. These are known as slow reactors, slow response of anaphylaxis. slowly reactive substances of anaphylaxis. They are LTC4, D4 and E4, and E4 gets further converted into F4 also. We don't go much in details of individually of them. We will study all of them at the same time, what are the functions, but maybe we can have some functions of C4 and B4, because C, D, they have same functions. As I said, this is I have taken just to show the difference, that there are slight differences in the structure, like this is H2, I said GHH2, so this bond is there, rest of them are there. This is two bonds, one is at 5th position, another is 13th position, H2, and then we see this is PGD, this is PGH, PGD isomerase. Here this oxygen gets converted to hydroxyl groups, and so this isomerase converts this H2 into E2. This is E2. So this one is oxygen, another is hydroxyl group. Rest of the structure is same as H2. You will find there are slight differences. See, this was arachidonic acid. There were 4 double bonds, as I said, and 2 of these bonds are saturated in the process, and then we get E2 series, means 2 double bonds. So this double bond is at 1, 2, 3, 4, 5 at 5th position, and 6, 7, 8, 9, 10, this is always 10th position, 11, 12, 13. So basically only 2 double bonds remain, one is at 5 and second at 13 position. This configuration is carried by all of them. Everywhere we will find one at 5th position, another at 13th position. Here also in E1 is at 5th position, another is at 13th position. So what changes? Only hydroxylation at few positions, like in E2 this 11th position is hydroxylated and this 16th position is hydroxylated. In this D2 opposite, here this is 15th, here this is 9th hydroxylation, another is oxygen, rest is same. So we can say D2, E2, I2 becomes different because the side chain it becomes different. So basically this is the reason they are all produced by isomerase, means there are slight differences in the structure. Yeah, for prostacyclin, for thromboxane, we have separate synthase enzymes, like this is I2 synthase, this is different, but remember this double bond position remains same in all of them. This is no need. This is how it is synthesized. So whenever we say that the arachidonic acid is derived from phospholipid layer, we always think that this is only the outermost layer. No, we can see it can come from sarcoplasmic reticulum also, that is also lipid layer. So from sarcoplasmic reticulum arachidonic acid is released. This arachidonic acids get converted with the help of COX-1,2 into H2. H2 gets converted into prostacyclin, D2, F2, thromboxane, all these are the same thing that we have seen earlier. This is leukotrienes. One more thing, this is lipoxin. If we see somewhere, not in this, maybe the next one. So this is leukotriene, arachidonic acid with the help of lipoxygenase, again LTB4 and C4. C4 will be converted into D4, E4 and F4, slow reactive substances of anaphylaxis. This is basically lipoxins. We are not going to talk about them, but they are also synthesized from the same pathway. These lipoxins, they have opposite action to leukotrienes, but they come from the same. A4 gets converted with the help of this into A4, B4, and with the help of 12 lipoxygenase, A4 gets converted into lipoxins also. We should remember the receptors of prostaglandins. Now we have a lot of knowledge about, prostaglandin receptors. So PGE2 receptors. We should remember there are 4 types of PGE2 receptors: EP1, 2, 3 and 4. EP1 has GQ transduction mechanism, this G protein, and rest of them, EP2 and 4, they have GS, and 3 has GI. And what are the functions? GQ we know through IP3 DAG mechanism. This will cause contraction of smooth muscles. There is no issues. GS, E2, EP2 and EP4, they act through GS, increase the CAMP. Now this CAMP increase causes vasodilation. What we have read in beta-2 receptor, in beta-1 receptors, that when CAMP is increased by GS, there is tachycardia and increased force of contraction of myocardium. But that is in myocardium. In smooth muscles, this CAMP, this causes phosphorylation of myosin light chain kinase. And this phosphorylated myosin light chain kinase becomes less sensitive to calcium. And so this gets relaxed. So this EP2 causes vasodilation, bronchodilation, uterine relaxation. And EP4 causes vasodilation, anti-inflammatory effects and bone formation. This EP3 acts through GI, decreases CAMP, and so this will cause gastric protection, inhibition of neurotransmitter release and fever. PGD2, it has 2 types of receptors. One is DP1, another is DP2. DP1 acts through GS, again vasodilation, inhibition of platelet aggregation, and DP2 acts through GI, it causes chemotaxis of eosinophils, basophils and T lymphocytes. PGF2 alpha, this has FP receptors, they act through GQ, increase IP3 DAG, uterine contraction, bronchoconstriction, increase aqueous humor outflow. This is the function of F2 alpha. PGI2, that is prostacyclin, it acts through GS, increase CAMP, and this causes vasodilation and inhibition of platelet aggregation. Thromboxane A2 acts through GQ, platelet aggregation, vasoconstriction, bronchoconstriction. So this is the transduction mechanism. Remember, all prostaglandins, they act through G protein coupled receptors only. What are the functions of these specialized types of prostaglandins? D2, mast cell, the place is mast cells, eosinophils and brain. And what does it do? Principally by recruiting eosinophils and basophils, induces bronchoconstriction involved in androgenetic alopecia. Some drugs are being trying to find out inhibitors of PGD2 for this alopecia, and so have specifically taken it. But D2 is responsible for recruitment of eosinophils. E2 is our main. E2 and I2 are our main prostaglandins. It is found in kidney, spleen, heart, macrophages. These are main places, but remember we have said these prostaglandins are found everywhere. And what is the effect? Effect depends on receptor to which it binds. We have talked about 4 types of receptors of PGE2. Binding to the EP3 receptors results in pro-inflammatory effects. This is responsible, EP3 receptors are responsible for inflammation. Binding to EP4 receptor leads to vasodilatation, whereas binding to EP1 receptor results in vasoconstriction, GQ mechanism with EP1. Vasoconstriction, enhancement of platelet aggregation at low physiological concentration and inhibition at higher level. So we can see PGE2 at different places can have different actions depending on the type of receptor that is present there. PGE1, just like I had said that we'll talk about PGE1 also. Endothelial cell, series 1 eicosanoid, functions by binding to both EP2 and EP4. counters effects of PGE2. Remember EP2 and EP4 acting through GS, increase CAMP vasodilatation. So it counters the effect of PGE2, induces vasodilation and inhibits platelet aggregation. When we say counters the effect of PGE2, because we are talking about that effect, vasodilatory effect of PGE2. And in the body, when we talk of cardiovascular system, we always say vasodilation caused by PGE2 and PGI2. So we always remember the effect of PGE2 is vasodilatation, and that is why we are saying counters the effect of PGE2. Otherwise, if we go for PG through EP1 receptors, through GQ, this is causing vasoconstriction, but that is not in the blood vessels. That is not vasoconstriction. When we say EP1 GQ mechanism, that means it must be in smooth muscles of GIT, where contraction is taking place. The smooth muscles of vasculature, they contain EP2 receptors and EP4 receptors. Involved in wound healing, alprostadil is drug version of PGE1, formerly used in the treatment of erectile dysfunction. PGF2 alpha found in kidney, spleen, heart, lungs also. Increases vasoconstriction, bronchoconstriction and smooth muscle contraction. F2 alpha, very easy to remember because acting only through GQ. H2, like I said, it is a general precursor of all prostaglandins, but it has some effect like induction of platelet aggregation and vasoconstriction. PGI2, we all know, causes ADP induced platelet aggregation, inhibits leukocyte aggregation, decreases T cell proliferation and lymphocyte migration and secretion of interleukin 1 alpha and interleukin 2, induces vasodilatation and increases intracellular CAMP. Thromboxane A2 found in platelets, causes platelet aggregation, causes vasoconstriction. These are the standard effects of thromboxane. Increases lymphocyte proliferation, induces bronchoconstriction. Leukotriene, B4C4, I said we'll talk about. B4 is present in monocytes, basophils, neutrophils, eosinophils, mast cells, epithelial cells. Potent inducer of leukocyte chemotaxis and aggregation, increases vascular permeability, enhances T cell proliferation and secretion of interferon gamma, interleukin 1 and interleukin 2, promotes adhesion of neutrophils to vascular endothelium. This is how inflammation takes place. Enhances expression of MCP1, that is monocyte chemoattractant protein 1, thereby attracting additional immune cells at that site. And C, this is also C4, found in monocytes, alveolar macrophages, basophils, eosinophils, mast cells, epithelial cells. Microvascular vasoconstrictor, increases vascular permeability, enhances bronchoconstriction and secretion of interferon gamma, recruits leukocytes to sites of inflammation, enhances muscle secretion, mucus secretion in the gastrointestinal tract and airway. So these are pro-inflammatory. B4, C4, and we are not talking about, but D4, E4, as I said, they are known as slow reactive substance of anaphylaxis. So what are the effects on the human body? First of all, we'll talk inflammation only. There are various components of inflammation. One is foremost, that is vasodilatation. What is responsible? PGE2, I2 and D2. All are responsible for this vasodilatation. Causes dilatation of arterioles and precapillary sphincters. Increase local blood flow. That is what we say. Causes redness, rubor, or warmth, that is calor. These are the signs of inflammation. Rubor, calor, dolor. Increase vascular permeability. Prostaglandins themselves have only a modest effect on vascular permeability, remember, but markedly potentiate the actions of histamine and bradykinin. So So effect is enhanced plasma leakage, formation of inflammatory exudate, that is tumor, another sign. Hyperalgesia, principal mediator is PGE2, most important. Mechanism does not directly produce pain, instead it sensitizes peripheral nociceptors to bradykinin, histamine, serotonin and substance P. These are basically the neurotransmitters at sensory autonomic nerves, substance P and the serotonin. Lowers the threshold of activation of pain fibers. And what happens? Dolor, tenderness at inflamed site. If we give injection of PGE2, then what happens? We get tenderness. This is a typical sign that there is no other effect. The inflammation is not produced, but the area becomes tender. Fever, principal mediator again is PGE2. Mechanism, exogenous pyrogens, for example bacterial endotoxins, stimulate macrophages. These macrophages release cytokines such as interleukin 1, TNF alpha and interleukin 6. These cytokines induce COX-2 expression in hypothalamic endothelial cells. Hypothalamic endothelial cells. Increased hypothalamic PGE2 raises the thermoregulatory set point. And what is the clinical manifestation? That is fever. So these are all signs. Modulation of leukocyte function also is there. This we have to remember, that PGE2 generally suppresses excessive immune response by inhibiting T cell proliferation. We only talk of pro-inflammatory action of prostaglandins. This PGE2 also is causing inhibition of T cell proliferation, reducing macrophage activation, decreasing production of certain cytokines. PGI2 inhibits leukocyte adhesion to endothelium, that we know, limits platelet leukocyte interaction. This action of PGI2 we all know. PGD2, it produced by mast cell, contributes to allergic inflammation, recruits eosinophils and Th2 cells indirectly. Thus, prostaglandins can exhibit both pro-inflammatory and immunomodulatory effects. D2 is causing proliferation, D2 is causing pro-inflammation, and they are modulating it, PGE2 and I2. Resolution and chronicity of inflammation. Prostaglandins influence the progression and termination of inflammation, just like we said. Beneficial effect is restricts excessive tissue damage, regulates cytokine production, promote the switch from acute inflammation towards resolution. Harmful effects, persistent prostaglandin production contributes to chronic inflammatory diseases, joint destruction in rheumatoid arthritis and persistent inflammatory pain. So prostaglandins, they have all the effects, pro as well as anti-inflammatory. But mostly we have to remember that for inflammation, prostaglandins are responsible. Then other effects, cardiovascular system. What happens to blood vessels? Vasodilation, as we said. PGI2 also. So because of PGE2, PGI2, even D2, they are all causing bronchodilation. They are all causing vasodilatation. Thromboxane A2 is producing vasoconstriction. So opposite effect, but we have to remember that this is present only in the platelets. This is not widely distributed, is not present in the endothelium. And so this effect is very limited. So what we get? We get only vasodilatation. Thromboxane A2, that is present in platelets, powerful promoter of platelet aggregation, facilitates thrombus formation, released mainly from platelets. PGI2, potent inhibitor of platelet aggregation, limits thrombosis, maintains blood fluidity. So there is a balance between these thromboxane and prostacyclin. Smooth muscles, uterus, PGE2 stimulates uterine contractions, all phases, promotes cervical ripening. F2 alpha, strong uterotonic effect. Again, the tone of the uterus is increases frequency and amplitude of contractions. So on uterus we have to remember both PGE2, F2 alpha, they cause contraction. Bronchial smooth muscles, D2, F2 alpha, bronchoconstriction. E2, mild but prominent effect is this. PGE2 is not that much present in lungs. Reduces release of inflammatory mediators. But remember, as I said, this is the prominent effect. GIT, PGE2, F2 alpha, increase intestinal smooth muscle activity, may produce abdominal cramps and diarrhea. GIT mucosa, both E2 and I2 inhibit gastric acid secretion. All these things we have to remember because we'll talk about the uses of prostaglandins also, but all these will be considered when we are talking about non-steroidal anti-inflammatory drugs. So what PGE2 I2 is doing, it inhibits gastric acid secretion, stimulates secretion of mucus and bicarbonates, increases mucosal blood flow, promote epithelial repair, protect against gastric ulceration, cytoprotective. So we have to remember prostaglandins through E2 and I2 both, they are gastroprotective. Kidney, both E2 and I2, they will cause increased blood flow, especially during stress. Dilate afferent arterioles, preserve glomerular filtration rate, promote natriuresis and diuresis, furosemide-like action, facilitate renin release, mainly PGI2. Even on chloride, there is increase, just like furosemide, the effect is there on chloride secretion. Eyes, F2 alpha is present, increases uveoscleral outflow of aqueous humor, lowers intraocular pressure. Reproductive system, PGE2 essential for cervical softening and dilatation during labor. F2 alpha contributes to initiation of labor, causes luteolysis in some species. So F2 alpha, E2. These are the prostaglandins and some more, we'll talk about them. They are present for use. Natural prostaglandins are dinoprostone, that is PGE2. PGE2 is dinoprostone. Gimprost, dinoprost is F2 alpha. Alprostadil E1, we talked about that. Prostacyclin is available as epoprostinol. And prostaglandin analogues are carboprost, F2 alpha. Misoprostol, that is methyl PGE1 ester. Latanoprost is PGE2 analog. And travoprost, bimetoprost. We'll talk about where to use them. These are the uses of prostaglandins. Obstetric and gynecological uses are maximum and in all stages. Normal delivery, termination of pregnancy, after delivery to inhibit postpartum hemorrhage. So induction of labor and cervical ripening, dinoprostone is used, PGE2. Cervical ripening before induction of labor and induction of labor at term, for both these purposes. Medical termination of pregnancy, misoprostol, PGE1 analog. First and second trimester abortion, usually with mifepristone, is done. Management of missed or incomplete abortion, that is again Gimprost, PGE1 analog, second trimester termination of pregnancy. Carboprost is 15-methyl F2 alpha, mid trimester abortion. So these are the indications of these prostaglandins. Control of postpartum hemorrhage, what do we use? Carboprost and misoprostol. produce powerful uterine contractions. Used in postpartum hemorrhage due to uterine atony when oxytocin is ineffective or unavailable. And we can go for carboprost or misoprostol. Then GIT, prevention of NSAID induced peptic ulcer. What do we use? Misoprostol. Very specific. Replaces the protective prostaglandin depleted by NSAIDs. Increases mucus and bicarbonate secretion. Reduces gastric acid secretion. Prevents gastric ulceration in high risk patients receiving NSAIDs. Ophthalmic uses. Treatment of glaucoma and ocular hypertension. Prostaglandin analogues increase uveoscleral outflow of aqueous humor and are among the first line drugs for open angle glaucoma. कौन कौन से? Latanoprost, Travoprost, Bimetoprost, Tafluprost. These agents effectively lower intraocular pressure and require once daily administration. Cardiovascular uses. One is pulmonary arterial hypertension. What do we use? We use epoprostinol, that is PGI2 analog. Iloprost, this is Iloprost. Iloprost, treprostinil. Potent pulmonary vasodilation, inhibition of platelet aggregation, improvement in exercise capacity and survival. Maintenance of patent ductus arteriosus. What do we use? Alprostadil. Keeps ductus arteriosus open in neonates with congenital heart disease requiring ductal patency until corrective surgery can be performed. Opposite to it is when we want to close it, then we give NSAIDs. Urological uses. Erectile dysfunction, again alprostadil, PGE1 analog. Administered by intercavernosal injection or intraurethral suppository. Produces penile erection by relaxing cavernosal smooth muscle and increasing blood flow. So that is use of alprostadil. So we will have separate session on NSAIDs.